transformation, making interprofessional teams shine. So again, if you're just joining us, there is a chat box option that you'll find if you hover your mouse on the lower part of your screen.
We will wait a couple of minutes. 2 minutes after 2 we will start. It's not yet 2 even.
And Olivia, if you can confirm that the camera is working on your end well and that you can see us in the screen.
If you can tilt your camera a little bit down.
Like, how's that?
Perfect.
Thank you. Great.
So the sound is good, Olivia?
Yes, sound is great.
All the way from Ottawa, still good?
Yeah, still great sound.
Partner organizations here. Can you write me the partner organizations quickly? Here, in the piece of here, I think the partner organizations are one.
Okay. On a fait le lien encore.
Okay. Welcome, everyone. Just one more minute, we'll get started.
She wanted to know the partners, but we have it all in the. We have it all in the presentation. Yeah, back up. She wants.
Oh.
Yes, get started. And let me just tell you what the presentation today will be. We have lots and lots of people participating, and we appreciate that. We appreciate you taking the time, especially the busyness that is going on. Maybe I will start just by introducing myself, Doris Grinspun, CEO of RNAO, and my colleague Susan McNeil, who works with me on the OHTs. But before I start on the OHTs, let me tell you and take a minute to say how impressed we are at RNAO with how the province and public health officials are working on the novel coronavirus. RNAO is intimately involved in it, on not just daily, but multi-daily dialogue with government officials. Everybody has been absolutely fantastic in answering our questions, anything, any ideas, any suggestions that we have had. Many of them have been answered and responded, and any questions that have not been answered, we have received a good rationale of why the approach might differ slightly. With that, I do want to move us, and I want to thank those of you in the field, especially if there are people from Sunnybrook Hospital and everybody else in the field in any sector. Thank you tremendously for getting ready, and being 2 steps ahead of the curve. Because if one thing we learned from the SARS experience, and some of us were again very intimately involved back then, was that 2 things were essential, and at the time, perhaps deficient both. One was communications, and now communications is an 11 out of 10. Back then, for several weeks, was 0 out of 10, with all the respect to those that thought that was better. And in terms of the use of the precautionary principle and staff protection, etc., throughout the SARS crisis, because it tended being a crisis out of poor communication, in my view, partially. but really, again, the people in the field, and I have spoken with managers, with senior officials, with staff, they feel that they are ready to go on whatever that go will mean tomorrow, the day after, and the day after. So with that, it's not that we can relax, but we can take assurance that we're working together collaboratively as a team and responding both to what the public needs as well as to what staff needs in order to be protected. So big thanks to everybody that is involved. And with that, let me tell you about what the webinar today is. It is our monthly webinar that does relate to health system transformation. So I will review briefly what this health system transformation means and where we are at, simply because we find that in the hundreds and hundreds of people that participate, there is a good number still of people that do not know sufficiently about the health system transformation, and it's for a variety of reasons. So we always take the opportunity to start from ground zero and move quickly so we are all on the same page. After I give an update on where we are with the health system transformation and with the Ontario health teams, we will have Greg Hein. Greg Hein is the Assistant Deputy Minister for Digital Health, and he will be presenting about the digital health plans for the province in relationship to the health system transformation and OHTs. And then, and that's the reason we are in Ottawa, is that we are here with our partners on the East Health team, which is a team, I think, by and large, Francophone. And I needed to step up my French overnight. I'm joking. They're all English speaking, but I do know a bit of French, but they're fantastic. So I'm here with the Estrie Center, which is a community health center, with the Ottawa Public Health Unit, with Montfort Renaissance, with Montfort Hospital, and Montfort Hospital has been a BPSO for several years already, with the Canadian Mental Health Association, with whom we work also in the other OHTs that we are involved. So with that in mind, just to remind you that RNAO is the professional association. Our role is to speak out for health and for nursing, although in the issue of OHTs, or for that matter, coronavirus, or anything more or less that we speak, we really engage with all partners across sectors and with all health professionals across all sectors, with an attempt to inform, influence, to advocate where there is a need to advocate, to celebrate where there is a need to celebrate, to connect people, to open doors, to protect, and hopefully in the process to inspire everybody. So I did go through what we will be doing in the webinar. We will leave questions and answers after each section, very briefly after mine, especially after the digital health and OHTs and Greg's presentation. We will leave a space for not only his update, but questions and answers. And we will leave also space after the presentation of our colleagues at the Ottawa East and how they're connecting the overall OHT that they're forming to specifically then the BPSO OHT component of that. And then we will again open for questions. So the Ontario Health Agency, you do know that they brought together 6 what they call now legacy organizations that are in the first row there under Ontario Health. My understanding is that the telehealth, what's called the Brown, the one that we do the webinars with indigenous communities. Okay, so the one that you all use to do health practices in distance is not telehealth. Neither. Neither. It will come to me, neither. It will come to me, I will bring it to you. That also, that is connecting into this Ontario Health Agency. And then of course you do know that Mental Health and Addiction Center of Excellence is being formed, and that's great news for the province because it will bring a significant attention to the issue of mental health and addictions. There are 5 regional offices with for transition, and those 5 offices have been named, and their CEOs have been named. Those are 5 CEOs that were previously in one of the LINs. So the LINs have been merged into these 5 regional offices. My understanding, and this is not from the government, this is me, is that these are transitional, if it's my understanding. So whether they will continue to be in this reiteration or in another form, time will tell. And then there are the Ontario Health Teams. And then of course, that's a slide from the government that still says 10 public health entities. That is under consultation now, whether it will be 10, 12, 15, time will tell what it will be. That's under consultation. The one that I was going to say that also is included now with the Ontario Health Agency and is being brought into the Ontario Health Agency is OTN. Okay, so it did come back. And OTN is what is being used to provide virtual services to distance communities, not only rural, sometimes it's other communities that need that type of specialty support. So what are the Ontario Health Teams? Very briefly, Ontario Health Teams are groups of providers and organizations that are clinically and fiscally accountable for delivering a full and coordinated continuum of care to a defined geographic population. Ontario Health Teams have as mandatory sectors primary care, hospital care, mental health and addictions, long-term care, home care, and community care. And the idea is that they wrap around the services of the population of individual patients in that geographic population so that all the services are linked. And ideally, people don't fall through the cracks and there are not many discharges, but a continuum of care between one sector to another. Where are we in the process as a province? The first call was done already for the Ontario Health Teams, and that call was responded by 30 people. From the 30, 24 were selected as Ontario Health Teams, and I will show you a slide soon of what their names are. And then there is the ones in development. Those in development, there are 41 that submitted proposals. And it is only a guess of mine. I have no more information than you, that probably whether it's April or May, all depends what's happening with other things in this province. They will also hear moving forward, etc. So from the ones that are Ontario Health Teams as we speak, these are the 24 that have been named Ontario Health Teams. I do want to stress, and this is with a good degree of confidence, that the other 6 that were not moved as Ontario Health Teams actually can reapply at their convenience. They receive feedback. They do not need to wait for another cycle. They can put their application anytime, again, of course, given that they respond to a few questions that they had in terms of areas that they needed to strengthen. So all in all, likely, whether the 30 we will have or not, we don't know if all the 6 will decide to go ahead. I want to believe yes, because the province, I think the public needs them. So who knows if we will end up, at the end of both two cycles with 60 or more OHTs. And then there are the innovators, which will come later, which those are on specific client populations. So these are the ones, these are the 41 that put a good letter forward that they want to proceed. From those 41, some will be selected to continue to the full application process. And this is where RNAO gets engaged with the process. From the beginning, RNAO provided letters of support to those those organizations within OHTs that are BPSOs, simply because we know their work. And then we also provided letters of support to some OHTs for the full application, to 4 OHTs that requested to work with us. And those are the ones that are to this date working with us. There are several others that have expressed a strong desire, should I say, push the door, that they want to work with us. And we are in the process of looking with which additional ones to proceed. So what is it that we are doing with that? So let me first explain about the BPSO in general. The BPSO in general, the best practice guidelines, is a program that basically speaks about, we have 52 clinical best practice guidelines, and we have 12 work environment best practice guidelines. These best practice guidelines are being implemented through a model of people working directly with us. What's different here is that we will be working with across all sectors, with all those organizations that become a BPSO OHT, and we are doing that to advance the goal of integrated system of care. So with that in mind, the goal is to optimize patient experience, patient outcomes through evidence-based practice and robust staff engagement. And that's what we bring to the OHTs. These are the 4 OHTs that we have selected at this time. All of them are well in their process to move ahead with evidence implementation, including that with some we have already done the gap analysis between what they are doing in the practice versus what the evidence says. We also have done a training of their champions. And today we're in Ottawa and you will hear from them. Today we started also with them. The 2 guidelines that are absolutely mandatory for any BPSO that works, for any OHT that works with RNAO in incorporating the BPSO OHT model for them, is the person and family-centered care and care transitions. And that goes really beautifully because person family-centered care, it goes without saying that that's something necessary across all sectors, and quite frankly, across all the organizations, because we can always do better, and that goes for each one of us as individuals, as well as organizations. Care transitions, if you think, is what actually the OHT is all about when we are talking about integrated systems of care. So if we're talking about integrated systems of care for these many partners that you see on each OHT, care transitions and how people will move from one sector to another in a seamless way is critical. So that's why those 2 BPSOs, those 2 BPGs are absolutely mandatory for any OHT. And I would encourage those of you that are OHTs or are members of an OHT and are not working with us, either because your OHT didn't approach us or because we didn't take you, at this point at least, to take those guidelines and also start to look on how you can implement them. There are tools in the website, like the toolkit for implementation. There will be additional tools for implementation that we will be sharing. And yes, in the go forward, we hope to be able to have the sufficient capacity from an RNAO staffing perspective to really embrace many, many more of the OHTs and work directly with them in supporting them. In addition to the 2 mandatory guidelines, each OHT will select or has selected 2 additional clinical guidelines. So for example, the Western Toronto OHT selected pressure injuries and falls prevention. And then in those sectors that were not really appropriate for pressure injuries as much, they chose the guideline on engaging with persons with substance use. And those were the sectors that have to do with mental health, and also sectors that have to do with primary care, that they felt that for them, that guideline was more appropriate. So all in all, that BPSO OHT is implementing 5 PPGs, and that responds again beautifully to the quadruple aim of patient and family-centered care, first of all, of improved patient experience, right? And then, of course, the guidelines on clinical guidelines, both the patient family-centered care, the transitions in care, the falls prevention, the pressure injury prevention, on improved patient outcomes, of course. And then if you end up with less falls and less pressure injuries and more satisfied patients, you lower the cost of care. And that's a good thing, is lowering the cost of care as a result of good care. Alongside with that, we have a very robust implementation strategy with staff, and we will talk a bit with you, and we will show you a slide of an unsolicited disruption that we had in one of our training sessions, and that tells you the level of excitement, and as some of them put it, the fire in the belly that these people feel once they're trained as champions in social movement practices, and how they bring that back to their units, whether it's a public health unit and a program, or whether it's home care and their colleagues and virtual care, or whether it is in a hospital at the hospital level. And I know Montfort can tell you what it did already to you in your capacity of BPSO Direct. This is the model that we have. Knowledge to action framework is what we have used. If we have that we have used always since the inception of the program. And the knowledge to action framework, this is the 2nd edition, again, is on the website. And the next edition, which will come about 10 months from now, will bring together 2 aspects. We'll continue with the knowledge to action framework, but we will bring more tools for actually how to do each one of the phases of the framework work. And also will bring the social movement action in terms of what are the critical attributes, what are the definition, what are the antecedents, what needs to happen before, what are the consequences. So people hopefully will be able to implement this across the OHTs and also in other work that is being done. This work is being sponsored financially, the 3rd edition, partially by CPSI. And CPSI also will use it for their own programs, and has been a beautiful partnership. This is the champions training that we did for the Northwestern BPSO OHT. It was magnificent. We had about 120 frontline staff of all disciplines. We had pharmacists, we had social workers, we had nurses, both RNs, NPs, and RPNs. We had mental health workers, we had physios, we had, you name it. And the beauty of learning together about how to bring evidence to practice and to then focus on this specific guideline and person and family-centered care was absolutely magnificent. The exercises we did together, the sharings that they did, it was absolutely fantastic. And we do want to show you what happened when we were trying desperately to wrap the 2-day event. And I was trying to talk and kind of bring a nice closure to it. Here is what it happened.
And you're singing.
So Susan put very softly when I was talking that we are the champions. And all of a sudden, people put the lights on the phone. They put the lights on the phone, and they started to dance. And that was the end of the thing. To make it even more fascinating, they had prepared a beautiful cake that said BPSO. So we had really a celebration that was just very heartwarming and amazing. So with that, I want to stop perhaps for I didn't want
So
to
it's
do
gonna happen
that.
again.
Okay, it will not come back again. It will go into, it's quite something. Huh? So with that, I want to stop for 2 seconds to see if there are any questions specific to this segment. Just to remind you, in relationship to the BPSO OHT, our colleagues from Ottawa East will be presenting, so you will hear more. So if there are questions in general, you may want to hold them till then. But let me stop for a second. I don't know if there are questions.
I do have one question.
Okay.
There's a question, is there a maximum number of health teams that will be funded?
By government?
That's
I
my
am
guess, but I'm
assuming that
assuming
that's the question. Government has not said that. First of all, the Ontario health teams at this point have not been funded. They have come from their own good volition to work together. Our government has not promised funding for the Ontario health teams. And to me, the fact that 31 had expressed interest the first round and 41 now, despite that, no one has been offered funded in the Ontario health teams. It shows the level of collaboration and the level of interest, and perhaps the most important, the level of just needed a trigger and a inspiration to being pushed to work together. But what I see now is just a very genuine interest to work together and a very genuine interest to simply do good for the public. So to me, that's heartwarming, and that's why we are exactly on the page of wanting to be with you, wanting to help you, etc. So I hope that answers. Whether it will be funding after, I couldn't answer, and I'm not sure Greg will take the option to answer on that one, because I don't think there are news on that. Yes, Olivia.
Hi, Doris. We have another question come in. In these new health teams, is the involvement of the various police forces, mental health and brain injury require an understanding and a cooperative effort?
Do I understand if there are other sectors outside of health care that are involved? Is that the case?
Specifically, the question is in regards to police forces, but yeah, you can definitely expand to.
So because I heard you to say mental health, I mean, for once we have here a colleague from the Canadian Mental Health Association, and in several of the other OHTs we are involved, the Canadian Mental Health Association is involved. So yes, police forces in none of the 4 that we are involved is, and I'm not sure that has been thought about. But if someone is from the police force and is interested on that, we would appreciate if they send us a little note and we can facilitate that conversation, because I think that's a very good idea, especially when we are talking about engaging with people with substance use, etc. So I think it's a brilliant question. So please, whoever asked the question, connect us. I can tell you that it's not only the traditional healthcare sector that is involved. There are many community partners that are being involved. Yeah, I think the question about the police force is a very interesting and a very important one, depending on the population being served and the areas of priorities that those OHTs take. Thank you, Olivia. Any other question, or we move to Greg?
Is Greg on the line? We're just going to confirm whether Greg is on the line. And
there I am.
Greg is on the line. If you can confirm that you can hear him, Doris.
We can hear him beautifully. Thank you so much. So let us put his presentation. We're trying to advance the slides.
No, it's okay.
Okay. So let me introduce you to Greg Hiller. He's in charge of the digital health strategy, and he's the Assistant Deputy Minister for Digital Health. And Greg Hein, thank you so very much for availing yourself. I know things are very, very busy for all of us these days. So it's very special thank, and we leave it with you.
Thank you very much for the opportunity to join this webinar. So because I'm running around today, I'm just teleconferencing in, and I don't have access to the webinar, so I will just note what slide I'm on clearly, and someone can move it to that slide. I think I'll start on slide 3. So I'd like to say that the underlying drivers behind the digital first for health strategy are obvious and intuitive, in that most Ontarians, and like most Ontarians, most people in Canada and abroad, have high expectations for being able to access their personal health information through digital means, and also to be able to secure their health services virtually. And you see some of the key metrics there that have been generated by third parties like Canada Health Infoway and by some of our own research. In order to have a smart strategy, we decided to look at 4 different lenses, and you see them on slide 3, starting with patients, who we know want more choice in how they interact with the health system. And I underline choice because there is one fear that's been expressed to us in an occasional way that when it comes to virtual care services, are we going to force people to use them as opposed to getting access to providers face-to-face? And that's certainly not the case. So we're underlining that choice. And the other is, we use the word there, control. You could swap in influence there, but patients want more influence over how their health information is used. Moving to the provider lens, I think it's fair to say that over the last decade or so, a lot of frontline point of service systems that are used every day by providers and provincial solutions have been created in ways that give short shrift to provider requirements, and in fact have had the unfortunate consequence of creating burden for providers, nurses, doctors, and others. And there are all sorts of reasons for this, including a lot of solutions being developed by engineers and computer scientists and health informatics folks who claim to be taking into account the requirements of providers, but really don't adequately do so. So we want to fix that. And there's that's something that I suspect, but you can tell me when we move to questions and answers, but that's something that resonates with you. It has resonated with the OMA on the provision side. The yellow lens is the innovation one. And I often roll my eyes at people for talking about innovation because it's often, frankly, rhetorical and doesn't have much behind it. But we really believe that Ontario has a chance in the digital health space to make some progress by developing solutions that meet care delivery needs, but also could be exported to other jurisdictions. And we're not doing what the previous government did, which was a good effort under the Bill Charnetsky Fund, as I call it, to have a pot of money to allocate to innovative proofs of concept. Rather, we're making some big structural changes, which I'll talk about, to encourage innovation. Then the last box is on government and broader health system. And there we'd like to figure out how to better leverage the rich data sources that we have, and also to streamline the delivery of digital health. And that's referring to both frontline systems and some of the provincial delivery partners, and I'm happy to offer more detail on that. So moving to slide 4. So this honeycomb diagram gives you a sense of the big deliverables for the Digital First for Health strategy, which was flagged in the previous budget and then announced in frankly, a modest way in the fall. And I won't spend too much time on that particular slide because the subsequent ones unpack it in more detail. You do notice the center of that honeycomb is PHIPA modernization, and moving to slide 5, it underlines the importance of modernizing that piece of legislation in order to improve how health information is shared. We all likely have our own stories and experiences of really worthwhile efforts since before HealthLinks and during HealthLinks and after and all the way up to now for all sorts of good clinical purposes, and especially to improve the integration of health services. People have tried to think of novel ways to share information and find out in the end it takes honestly from 6 months, sometimes 18 months to arrive at data sharing agreements, often because legal counsel for health service provider organizations often want to minimize the risk and liability of their own organization, but in the end, what it leads to is poor sharing of information. So we know that it would have been we would have been heading down a road of constrained success, if I could put it that way, with Ontario health teams if we didn't learn our lessons from HealthLinks and tackle directly through some legislative and regulatory changes to PHIPA. And slide 6 gives you at a high level some of those buckets that we're working within. So when it comes to the system interoperability and digital tools, we're creating new provisions to support sharing across Ontario health teams, and we're going to be developing a framework with input from Ontario health teams and others to do that. And then there's that technical kind of dry term of interoperability, which you've probably heard before, which really amounts to having the right standards in place to compel the sharing of information, because there's really no mystery as to why we don't have a fully interoperable system up to this point. It's simply because there haven't been the levers in place, whether that's in the form of standards or funding, in order to, I'm going to use the word compel, to compel the managers of frontline systems and vendors and our own provincial assets to comply to the same standards, so that we can have a free flow of information, as happened in the United States, the UK, and lots of other countries where they don't have this problem anymore. It really is like playing tennis or a hockey game without rules and officials. We've essentially been doing that up to this point. The second on that slide 6 is we've been asking for and receiving cabinet approval to link information in ways that we haven't been able to before. And now I'm talking about de-identified PHI, so it's no longer PHI. But if you think about the richness of the data from social services, mental health, and the full panoply of other health data, we, as a collection of ministries and with our partners, really have left that data unmined for interesting findings and to harness it for capabilities like predictive analytics. So there are a lot of people that are really excited about that part of it. And then the bottom one on slide 6 is saying we don't want to make it easier to share information without also strengthening privacy protection itself. So there will be some enhancements to the penalties and offenses for violating PHIPA. And while it's not mentioned there, we're also working on cybersecurity with the Ministry of Government and Consumer Services, because we do know, and it's shown in the media, that there is a trend towards increased ransomware, malware, and data theft in the health sector. We're certainly not immune from that. In fact, we're a fairly interesting target for criminality. Moving to slide 7, virtual care is there's a curious situation in Ontario, in that on the one hand we have Ontario Telemedicine Network, which has been a world leader. It happens to be one of the bigger telemedicine virtual care networks. But on the other hand, it's really used only by certain providers and in certain areas of specialty, with for example, less activity in primary care. So if you look at the distribution of virtual care use, it's not at the level and spread that it should be. And it may sound remarkable, but in high-performing systems, virtual care can get upwards of 50% for primary care, and lots of post-acute activity can also be done through remote patient management or monitoring. And we think that that's a really rich terrain. We've been spending, as we have to, and you can smile at this or cry, a lot of time with the OMA because one obstacle has been clarifying the compensation models for all different physicians for video conferencing and for non-video forms of communication like secure messaging. And I'm happy to chat about that further. We also are trying to set the right standards so that you don't have to use OTN technology anymore, and OTN is helping us with that, but we want to move to a vendor solution agnostic approach, and so that we reach those substantial numbers on virtual care. And in a couple of areas, including this one, we appreciate working more directly with RNAO to get input from you on your perspectives on how virtual care could be integrated into health service delivery more effectively, because we do not want to just have conversations with the physicians. That would be skewed. Moving to slide 8.
Great.
Funny
Great.
in a nice way, every time you brief a new Minister of Health, including Minister Elliott, when we first met her, everyone always says, for intuitive good reason, that if we can do restaurant bookings online, why can't we do healthcare bookings online? And it's kind of apt if you think of a single health service delivery organization. It is obviously more complex if you want to do integrated online booking. Right now in Ontario, you'll know from your own experiences that some organizations do it and others do not. It's very uneven. But we want to find a way, starting with Ontario health teams, to set some requirements and also offer assistance in how online booking is done, because we really do think, and it's borne out in the empirical survey numbers, that a lot of Ontarians do want to access PHI, but frankly, another category is simply convenience. And we hope that it can be done in a way that also makes it easier for healthcare providers by taking, frankly, an irritating part of work and digitizing it. Moving on to slide 9. This is obviously a big priority and one where Ontario and other jurisdictions have flagged in, and that's providing digital access for patients. Again, touching on the theme of unevenness across the province, if you are fortunate for lots of reasons to be a patient at Sunnybrook or UHN or other hospitals, you do have access to some of your PHI, and we do find that some patients really appreciate that. Other patients don't use it at all, and that's fine as well. It's based on patient choice, as I mentioned before. We do want to find a way to give patients the choice in not only whether they access it, but how they access it. We don't think that portals are the only answer. In fact, we think the big answer is in applications, apps that are tailored to chronic conditions, and there are some great ones out there already, but we will be making some changes to PHIPA to circle back to that, which will allow for what's called a consumer electronic service provider, whereby third parties can secure data directly from our big repository and present it in applications that patients consent to, and that will be an innovative boom for us as well. And likewise, that's done through OHTs, both in the form of a requirement and assistance that we'll be giving them. Moving to slide 10, this is a big category of more connected tools for frontline providers. There are different dimensions to this. One is we do think that there are too many frontline digital health systems. You look at hospital information systems or EMR systems, the number of instances, to use a technical term, is too many for the province. It costs too much. It takes away money from frontline care. It creates a cybersecurity risk because a lot of those instances are insufficiently protected from threats. And often when HSPs go to market for those systems, they often don't get the best competitive rates. So we want to lower the number of systems. At the same time, experts would tell you that the real bang for the buck is in clinical standardization. And that's something that if you're interested in providing input on, we have a consultation right now, and really advice from consultancy and academic experts is that the more you can standardize based on evidence, whether it's order sets or in other ways, it provides a better standard of care and can also make health service delivery more efficient. We could do all of that and still be lagging behind other jurisdictions if we don't do what's on slide 11. And I just noticed slide 11 doesn't have a number, but it's the data integration and predictive analytics slide. And there it really is. This is where you do get into some trendy jargon around AI or artificial intelligence, big data. But what this simply amounts to is that when experts or big vendors like Apple or Microsoft come and visit us, they frankly don't say that we have amazing technology solutions. They say they're okay, but what they really are greedy to get their hands on is the hundreds of millions of points of data on drugs, immunization, diagnostic reports and images, you name it, the list is very long. And we ourselves, not only as a ministry, but as a health system, have to make better use of that data, as I said before. And we're looking to do that through the changes I mentioned to PHIPA, but also really getting, helping some OHTs do proofs of concept on how to do that. Skipping to the last section before opening it up to questions is on Ontario health teams directly. And we do know from the literature and from experience that if you look at models of integrated care in other jurisdictions, they are highly dependent on well-functioning digital health solutions. And so that's why you see those requirements for OHTs and why we published the Digital Health Playbook to help the sector understand the objectives of what we're trying to do through the strategy. And it really just underlines a lot of what I've talked about so far. So maybe I'll just end by giving you a sense of the status of where we're at with OHTs on the digital side, and some of you may know this already. So we are intensively working with the first 24. We've obviously already looked at their incoming digital health plans, but we're now working with them and provincial partners like Ontario Health, Ontario MD, Ontario Telemedicine Network, and others to fill in some of the gaps, because there are obviously some gaps. Sometimes it's in the form of, not using some of the existing provincial solutions or using them as effectively as possible. And in some cases, it requires some process redesign or some different ways to use some of the existing technology to share information differently. And in the odd case, it may result in acquisition of some new technology. But obviously, in a time of fiscal constraints, we don't necessarily see lots of technology acquisition. I did, at the tail end of the previous session, heard questions about funding, so I'll just be candid and share with you what I know up front before handing it back, and that is we were intimately involved in making proposals, funding proposals for digital health broadly and in support of OHTs in ways that match up with the big deliverables I just walked through. And you may know process-wise, the government is at that stage of having seen various ministries' multi-year plans, which is like a business plan on providing business cases for spending funds. And we're now heading obviously to the budget. So the government will be making those effectively policy choices about where to place its investment. And we're modestly optimistic that there will be some funding, but I think as Doris used the language, there are no guarantees, we don't know for sure yet, but there's a sensitivity to understanding the benefit of eking out some investment funds in support of OHTs to back the really exciting commitment that has been shown by the sector. So I'll stop there to leave time for questions.
Thank you so much, Greg. That's excellent. So you were for a minute talking about the link with RNAO. I want to tell you that first of all, each one of the new guidelines from now on as a virtual component, some of them already have, but we are ensuring that any new guideline has a virtual solution to it. Also to tell you that another piece that is important to look in the context of your work is the order sets. So each guideline already has order sets that can be embedded and places, for example, like Bayshore and many others have embedded them in their EMRs. So that, of course, is available and free of access, of course. The other thing is we're working with a point-click care to embed the recommendations of the guidelines in a way that for long-term care they can be used free of charge with any one of their technology solutions. A piece that I want to make with you, and that we will do that off the record because I want to open the questions, is that we have inquired, which is a massive database of the performance of the guidelines on patient care. And that's where we need to actually introduce also AI for knowledge production. But if you look at places like River, they have introduced a tile that is specifically on all the guidelines that they're implementing. They have reduced, for example, pain scores tremendously in a matter of a month. So, you know, both the surveillance, the ability of having that on the tile on their command center, plus the strong evidence of the guideline is producing magic already. So
that's exciting, and we are aware of the existing uses of marshalling clinical data and standardization, like the order set, and other examples. System coordinated access out of Waterloo Wellington does too. What you'll see when we share the consultation document is that we're trying to propose a broader program of clinical standardization so that it takes all of the hard work of deriving quality standards and other clinical content and turns it into usable code for all frontline systems, and in a broader way than just order sets or just long-term care, because we think up to this point it's been good, but it's been a bit fragmented.
That's right. So the order sets of RNAO, they told me to move from the mic. The order sets of RNAO can be incorporated on absolutely any EMR, any. The difference between our order sets and some other products is that ours are evidence-based using the GRADE methodology. So they're being used in other places, right? In other countries, they should be using ours too, right? So let's meet and talk about that more, because that will be very good. I was talking with Brown from OTN about that.
Right.
In any case, let's move to the questions from my colleagues because I certainly have interacted to dialogue with you. Let's move to we have already close to 400 people that I'm sure some of them have questions. Olivia, back to you.
Yes, hi Greg. Thank you so much for your presentation. The chats have been quite active, so I do have quite a few questions for you. We can start with whether you can expand a little bit on what you mean by innovator and talk a little bit more about the innovation initiatives that would lead to economic development.
So we're pretty agnostic on who would be defined as an innovator. So in some cases, it's folks out of UHN that have done Medley. In some cases, there are third parties that have done apps like .health. It's really, there's a burgeoning Ontario market. Some of them are represented by an organization called the Council for Canadian Innovation. And so the changes that we're making, one of them is, it sounds technical, but it has an exciting outcome. So the interoperability rules of the game are going to say that every holder of data, every major holder of data, so frontline systems like hospitals, all of ours like the lab information system, have to publish APIs. APIs are application programming interface protocols. It's simply a way for one solution to talk to another solution. And along with messaging standards, and you see what I mean, it gets a bit boring, but also clinical content standards. So if you look at the EU or you look at the United States, we have to say, what are the 20 or 30, I'm making this up, most important data points, clinical data points to share from acute through primary care, through home and community care in support of OHTs. And we're consulting on that, and we're happy to add that to the list of our discussions with you. So how does this allow for innovation? Well, it opens up systems that have otherwise been locked up, some that are run by multinationals, and it allows Ontario companies to be able to develop value-added applications on top of those big hospital information systems. We're also publishing standards for virtual care, and there are some Ontario-based virtual care companies. And the last one is not the last one, but another one is the Consumer Electronic Service Provider Authority under PHIPA. Excuse me. So all of these are opening up Ontario's system so that the data that we have can be shared for multiple purposes, both PHI through consent of patients and also de-identified for research purposes.
Okay, thank you so much for that. I also have another question about, and I'm not sure if you can, how much you can discuss that or explain a little bit more about, but are there any plans, and if there are, what are the plans for scaling up e-consults?
Yes, so e-consult is funded out of my division, and if you look at the expected rates of growth, it's an upward trajectory. And what the big change for this year is that we're trying to create a single program between e-consult and e-referral. So depending on where you are in the province, you will use one of two e-consult systems or one of 3 or 4 e-referral systems. And we'd like them to be run out of the same program. And we're talking to all the right people about that, the Ottawa area folks for e-consult, OTN, Waterloo, Wellington folks for e-referral, and others to use Novari, dotted throughout the province, so that they're all using the same standards and that we can offer a more holistic program. Because if you think about the flow of e-consult and e-referral, there are some overlapping processes that we should net out.
Okay, great, thank you. And I have a bit of a two-parter. Are there plans as part of Digital First for patients to be able to access their data using personal health records? And also, will there be transparency for patients to know exactly where their data is being shared?
So on the first one, yes, that was one of the big deliverables, to be able to, through OHT requirements and generally making those changes to PHIPA, to give Ontarians much more choice in how they access their own PHI. What I didn't mention previously is that we also want to embed in PHIPA the right to access your data digitally, and that hasn't existed before, and we want that to empower patients. And then, yes, there are jurisdictions like Estonia who are leaders in giving patients not only control, but visibility into exercising that control about who's accessing their data. We do want to get to that place, but right now, when it comes to consent, we are technically limited to mostly global consent at the provincial level, but we're talking to the Information and Privacy Commissioner and other experts about how to give patients more choice in how they give or not give consent, and how they're aware of those who are accessing their data. So right now, it's at the principal stage and not at the implementation stage.
Okay, great, thank you. And I have one more about the digital health patient interfaces in relation to those populations who may not have internet access at home or in rural communities, or those who experience homelessness. So what alternatives to digital health patient interfaces will be available to those populations?
It's true that we live in a world of seemingly ubiquitous access to internet, but we're aware of the broadband and other technical limitations in rural and remote areas, and there are other parts of government, namely Ministry of Consumer and Government Services, and some third parties who are working to improve that. So we're aware that we shouldn't just be assuming that people have access, and we're also talking to Ontario Health about how to ensure equity as a principle in accessing. It is one of the, one friendly debate that continues is, do we give multiple channels of access, or just make Ontarians go through a single portal, like a trillion portal, so to speak? And we're favoring multiplicity of access, but that's in a way that still gives Ontarians a broadly similar experience when they access data, no matter where they're at in the province. So we definitely don't want downtown Toronto or people who live in big centers to have greater access than those in rural and remote areas.
Okay, great. And I have one more question, if you would so indulge. It's based on what part of your presentation where you were discussing concerns around OMA. So the question is whether you can elaborate on the concerns of the OMA regarding the compensation of practice models for using virtual solutions.
Yeah, I should say that it's not a concern. It's been a good partnership. If you look, it's been in the media, so I don't feel like I'm divulging anything, but the relationship, the governmental relationship, successive government's relationship with the OMA has been rocky at times. We have a great relationship with the OMA in that they do want to see increased use of virtual care, but there are some rocky parts to get through, like removal of a telemedicine premium that was paid on top of the face-to-face fee, and that was a historic one to allow for the fact that sometimes doctors had to travel to telemedicine suites when you couldn't do virtual care in a mobile format. So it's just figuring out. And sorry, and I should also say that we've achieved agreement on video conferencing, and we landed on equivalent compensation. So face-to-face and virtual are just different modalities. We're not going to charge less. We're not going to charge more. And that may sound obvious, but that was a major breakthrough. What we have to move to next, which is maybe going to be a bit more challenging, is how do you assign a value for secure messaging when we know, if you think about how you message your colleagues or your family and friends, it can be done in a faster way, and what does that constitute as an assessment virtual care discussions about compensation. We want to work with other major partners like you on how to make virtual care a more integral part of health service delivery.
Okay, wonderful. Thank you so much, Greg. I think that's it for questions on my end. Susan, are you still, and Doris, are you still on the line? Okay, so I'm not sure if anyone else has any additional questions for Greg. That was a wonderful presentation. It was very informative. Thank you so much for calling in and taking the time to share all this information with all of our members. So thank you so much, Greg.
Yeah, it was great. And let me know if about follow-up, and you can take it from there. Thanks very much. I'll sign off now.
Okay, wonderful. And if anyone...
Stay, and please stay, Greg, if you want to stay, I can afford the time.
Yeah, unfortunately, I have to race off to another meeting, but this was really productive, and I look forward to follow-up. Thank you very much.
Fantastic. Thank you so much.
Bye-bye.
So now we will set the colleagues of the okay? And your turn.
We're back on video.
Are
We're
we?
back, yeah. And
Okay.
can you just confirm, Olivia, that you can hear us again and the sound should be just a little bit crisper this time around? Yeah.
Yes, yeah, I can hear you.
Excellent.
Okay.
Nice.
So here you go, your turn.
Okay. Let me just move this slide along here.
Perfect. Excellent. So hello everyone, my name is Melanie Potvay and I'm a planning support for the East Ottawa Health team. And I'm speaking on behalf of the partners here in the room and also our other partners. We have 33 signatory partners as part of this Ontario Health team. And we have 5 that have currently signed on to be part of a BPSO, and you see all of us here today around the room. So I will present on behalf of the partners, but of course everyone's always free to jump in if I forget something interesting to note. So again, this is the membership that we have currently with our Ontario Health team, and I have to say it's growing every day. There's always a lot of interest. We're really fortunate to have the full continuum of care engaged right from the get-go, from our self-assessment stage, from primary care to home and community care to public health and preventative care, to a lot of community support sectors and community health teams, and to specialty services, hospital, continuing care and long-term care and palliative care and everything in between. So we have a really broad membership, and that's helped us to look at things from a much more holistic perspective. We've gathered around a common vision with all of the partners right from the self-assessment stage, which was the first initial stage in April. We decided that we wanted to work together to really create the best Ontario Health team for our population, and that was really an important word. I think all around the table we use different terms depending on what part of the sector and service delivery that you offer. Some people call, those that we serve patients, others clients, others people. So population is broad enough that it encompasses everyone, and we really want to look at it from a population health management perspective. And the focus of our improvements are really about interconnected care. So everything that we just talked about, digital improvements are really key to that, but also just how we collaborate together organically and informally, or better connect our processes, more streamlining. And we really want to contribute to the health of our citizens. So the health of our attributed population, looking at it again from that lens, not just health service delivery, but really keeping those healthy that we serve. And in both official languages, of course, because that is the demographic of which our attributed population that we serve. We've aligned our efforts with the quadruple aim, and again, this is the terminology coming from the ministry regarding the outcomes or the overall goals of the quadruple aim, and we've looked at our desired outcomes a bit more specifically, and also very specific objectives according to our target population for these desired outcomes. I'll talk a little bit about our approach to planning, because I think we took very seriously the idea that the co-design and engagement of our partners was really a big part of it. So not only is the content of what we develop important, but also the process in which we develop it. We put forth, after we were approved for assessment and went on to full application in July, we put forth this to our partners through an all hands forum and said, what do you think about this planning structure? And so we have a steering committee where there's representation from each of the service sectors, and also membership of the clients or the patients or the people that we want to serve that are on that steering committee, and they are voting members. We have a planning team that supports the steering committee and all of the working groups that was also put together. So we had a working group on the data, target population, and priority objectives that looked at how we should narrow down our objectives and our target one population. We had one working group, another working group that was about the clinical transformation. So what are our interventions that we want to implement to really transform care based on our population and our objectives? And another working group on IT and digital health. So we had multiple planning sessions, all hands with all of the partners, and then focused on the different expertise that we needed to develop the elements of our proposal with the co-design. Again, at each table, we had patient partners or clients or people that we wish to serve and their families to help influence the work. We also had consultation that was much broader than the people that were there that we'll talk about. But basically the key message here is that it was very resource intensive. There was a lot of work happening in a very short period of time. And again, I always take the opportunity to thank all of the partners, because it was really a matter of everyone moving their agendas to make this happen. And we couldn't have gotten to where we are today without that really active participation and engagement and that co-design work. This is a bit of a graph to show sort of the elements that we did from July to October to put forth our full application. As I said, we had some very intense collaborative forums. We also had some broader consultation. We had some family physician surveys. We had some focus group of family physicians. We had more targeted outreach for the community that we wish to serve. We looked at a lot of the bodies of information that already existed to help serve our work. So, and then at the end, before we submitted our full application, we had a governance forum with all of the board members of the different partners to come together to approve our full application before we went through. So again, very resource intensive, very engaging, and very collaborative. With the work that we did in the data that was looked at, we looked at the targeted population for our year one, and we did choose COPD. And the reason why we chose COPD, because it could be initially seen as quite specific. But in fact, a lot of those suffering from COPD have comorbidities, and a lot of them have a mental health and addictions component. And when you look at it from a holistic perspective, and a lot of our patient partners actually at the table really challenged us on this to say, why, are we really treating this population in the best way that we can in a holistic way? We have some data already to know that we have some improvements in Champlain and with our sub-region regarding the readmission rates or the revisits to ER. We know that we can do some proactive things there, but are we really addressing all of the elements in terms of prevention of COPD to palliation? And are we really addressing all of the components? For example, are we addressing the person in the household who might be smoking, that we're not treating the COPD, but that could be contributing to that? Are we addressing the children that might be in the household that have anxiety, watching their parents suffer from COPD? So that's really the holistic approach that we're coming to it with. And it's also something that we feel strongly that we can implement, learn from our rapid improvement initiatives and implement much more broadly, much more rapidly. And we have decided to focus as well on a second priority population in the second half of year one, which would be mental health and addictions, because again, very interrelated with this population and lots of work to do. And we also chose this population because it can really involve all of our partners, from prevention and health promotion to home community care, to primary care, to specialty services, to palliative care. So you can really see everyone and getting involved. Not to go into very much detail on this slide, but it does show the level of detail of planning that we got to, which is actually quite specific. We took, a case of someone with COPD or someone who might be healthy, and then how the disease could gradually progress over a lifelong process, and then what are the interventions that we could improve upon. And so we did go really, really specific actually, and talk about every intervention. So that was quite detailed. Of course, there are always lessons learned as we do these things, these rapid implementation. But I think that we understood quite quickly that the transparency of our work, the co-design, and the building and maintaining of the relationships really enables frank discussions. So you really got to put in the time and the effort, not only in the content and the specificity of what you're doing from a clinical, but also from the partnership piece, and build on the partnerships that you already have that are strong, and let that expand and do some a different kind of work to really help that relationship along. And again, we're lucky to have that full continuum of care, and I think that it's really been helpful for us because we're able to have a holistic view. I think that through the questions that we've received back from ministry, because we know that we fully expect to be number 25 out of the 30 that will be named. But we did have to put a little bit more emphasis as to how our specific target population can be extrapolated quickly for a full attributed population. So we're trying to demonstrate that a little bit more in our responses right now. And we definitely want to emphasize the importance of primary care and recruitment of family physicians in your attributed population, because that's a really key way to ensure that you can really fully expand to your full attributed population. So, and recommendations moving forward as well is just the term. If you look at some of the data coming, a lot of the data coming out in the frameworks of the Ontario Health Teams still talks about patient, and we're trying to make that much more broad at our level. We think that there still needs to be some focus on this offering of French services and making sure that we're looking at that, and also the other marginalized populations. How are we making sure that we're fully addressing those needs, and we're evaluating that in the context of OHT development. And the can't be stressed enough the competencies that you require, the clinical and IT competencies that you require, and does every region have the same level of competency? And perhaps there needs to be some looking at that from a broader perspective and distribution of that competency to make sure every health team is positioned for success. So in short, I would just, make the link that definitely the organizations around the table obviously see the value of being a BPSO in this context. I think that the two best practice guidelines of transitions in care and patient and family-centered care fully align with this, and we're tasked with trying to find 2 other clinical ones out of the many BPGs to further our work. And we can see how easily this integrates within our implementation plan that we've already put together for our OHT. I don't know if there's anything else that partners would like to add before I...
Just one of the things we've been discussing is the, for the 2 possible editions of the as yet undecided guidelines, looking at the integrating tobacco interventions and engaging clients who use substances. Clearly these fit in so well with the range of populations that we all work with, and really link well with COPD as well. So those are 2 guidelines that from BPSO that we've really looked at today as well for looking as possible. Going forward, it would be great.
Yeah, perfect. Okay, and with that, I'll pass it around to Suzanne.
I just want to say, Suzanne, I think there are some questions
Yeah.
that I will
Absolutely.
see. Some are directed to me, so I will answer.
Okay, sure.
Yeah, go for it, Olivia.
Okay, great. We do have quite a few questions here coming in. So how do individuals know which OHT they will be assigned to? Is it based on their geography, or is it their primary care provider, the indicator? And what happens if a family doctor is outside of the individual's neighborhood?
So that's a very good question. So for now, the individuals that fall within an OHT, that their family practice is within that OHT, will be within that OHT. How will this be pushed in the future is a question mark. I can only give you my guess. And my guess is that from now till before elections, most or many healthcare organizations will be aligned into OHTs, including from the new 41. If the new 41 fall in the same place, they may be standalones. They may be actually be asked to merge into existing ones in that area. Like for example, Ottawa already has 2. Like it has 1 already. It will have you guys, that's 2. My hunch is if a third one is in the 41, they will be asked to join one of those 2, because you can, unless it's a very large area, right? Like Toronto, right, or whatever. So remember, the OHTs were meant for relatively large populations. So that has not been decided, or at least it's not public. I'm just giving you my best guess.
Okay, great. Thank you for that. We also have another question asking, how will OHT outcomes be measured, and is there provincial oversight?
Yes, outcomes will be measured. They actually are being asked to measure outcomes. I can only speak for the part that has to do with BPSO OHT, but in general, overall in OHTs, they will be measured, and they're looking into that. And in relationship to the BPSO OHTs is inquired. They will be measured. So in BPSOs in general, we have 2 very strong measurement tools. One is the MyBPSO, which is the qualitative reports that BPSOs are asked to complete twice a year. Those actually serve for rapid learning as well as for evaluation. Each BPSO direct as well as the BPSO OHTs has a coach. That coach sits and reviews the MyBPSO reports, and together they do rapid learning on what areas need to be tweaked, improved, etc. The second is Inquire, the massive international data system, and that's what Greg also was referring to. And that data system already is measuring significant amounts of indicators on process, on structured process and outcomes for the current BPSOs, and will do exactly the same for the BPSO OHTs on the 4 guidelines that they will be each implementing.
Okay, great.
And just so people know, on Inquire as an international advisory, and on that international advisory, there are also people from WHO, including the chief nurse from WHO, Elizabeth Tyro, but also others. And there are top people from OECD, because they're very interested on the link between that and other international data systems to be able to ascertain the impact of nursing on outcomes.
Okay, great. And speaking of Enquire, we do have a question about that. Would RNAO ever consider sharing the Enquire database beyond BPSOs?
You mean opening the database beyond BPSOs? That's a question that is being pushed very much by IAC, International Advisory Committee. We are considering that, and government also has asked us if we will be flexible and other words like that to consider any opening of Inquire for non-BPSOs. In relationship to Ontario, if the government were to put a formal request that we open it to non-BPSOs, we will do that. Internationally, we will need to think and talk more with the advisory. Our interest on Inquire is actually to open it sooner rather than later for comparative analysis, contextualized to local settings. We do not believe, nor does the international advisory, that the comparisons, for example, that are done in the US between whatever hospital with whatever other country is necessarily useful for the issue of clinical guidelines impact on outcomes, because context has a big, big impact on process and outcomes. but for local comparisons, yes. And the other piece where we want to open it sooner rather than later is for research capacity, because there is a lot that can be learned from the data and inquiry, because it's massive in terms of practice and outcomes.
Okay, great. And do you
So
have,
whoever was the person that asked if inquire, if we're willing to open inquire for non-BPSOs, tell that person to connect with me. If it's the same person that has been speaking with me twice a year every time from Ottawa, I will not say who. In any case, we can still talk, but if it's other people, please to connect with us and we will look at ways or what. Yeah.
okay, wonderful.
I will, it's that good, and I leave now Suzanne. Suzanne to present. Okay, fantastic.
Thank you.
Hello, my name is Suzanne Robichaud. I'm VP of Clinical Services, Chief Nursing Officer at Montfort Hospital. To talk a little bit about Montfort Hospital, we've been BPSO since 2009, and Montfort has implemented best practice that have positive impact on patient care, and we have successfully maintained our designation as a leading best practice organization. We currently have 10 best practice guidelines implemented in various clinical settings. And we have demonstrated to RNAO that Montfort has the skill and the expertise to become a host organization. We will be the first Francophone host BPSO nationally and internationally. And we are actually in the planning phase. We have 3 hospitals that have showed interest, and we have commitment that they will become BPSO. We have a clinical lead at this point, and we are beginning the planning phase. Why do we believe that becoming BPSO OHT is so important? Is that our nurse and interprofessional staff involved and are excited about best practice. We have evidence that we have improved by creating a network, and we share expertise, we share tools, we can look at the amps. We also give us a jump start in highlighting nurse contribution to healthcare and providing evidence base. And we also have a mountain of evidence that shows that BPG's implementation contributes to better outcome for the client, for the population, for the nurse, for the team organization and healthcare systems, to a lower cost and a better value. So we really firmly believe that BPSO OHTs will optimize patient population and outcomes, and will have better integrated healthcare systems. And I'd like also to say a special thanks for RNAO. We wouldn't be here today if it wasn't because of their leadership. Thank you.
Excellent. So thank you very, very much. And thank you to Montfort for the terrific work that has been doing. And Susan, your colleagues that do tremendous work. Any questions?
Yes, actually I do. I have a question in relation to where does public health fit within the OHT structure?
Very good.
And what role or partnership would public health have within the OHT?
So it is interesting that government in the RFP did not put public health as a mandatory component. And likely it's not because government doesn't think it's mandatory for Ontarians, but because they have their view of what the role overall of public health will be, and the issue of the mergers of some public health units, etc. And that's the consultation they're conducting now. We, in our work, absolutely are integrating, as you can see, public health. So here we have the public health unit in Ottawa. In South Lake, we have the public health unit there. And simply because if you take the issue of population health, right, and health promotion, disease prevention, the sectors where health promotion, population health is public health, health promotion, disease prevention happens in public health, happens actually in primary care, whether it's community health centers, whether it's nurse practitioner-led clinic, etc. It happens in home care, and for that matter, it should happen, not always does, even in hospital care, right? Secondary prevention, for example. So we do integrate public health, and we are very pleased about that.
Great. And then I wanted, perhaps you can elaborate a little bit more about, other than more collaboration between community and health partners, how do OHTs differ from LHINs?
Oh, it's kind of, I hope that I'm not going to offend nobody from the LHINs if they're attending, but it reminds me of the question of how is this coronavirus different than SARS. It's night and day, I'm sorry to say that. While the LHINs try to do a lot of good work for a variety of reasons, some of their own doing and some of government not giving them enough rope, not funding, but rope. They did not, for the most, achieve the level of collaboration, integration so fast that we're doing now. Look, we just started this, and you can see the teams already moving and training, and I see all my colleagues nodding here. I believe the LHINs, from our perspective now, from RNAO perspective, the LHINs tended to centralize more than what probably they needed to centralize, and therefore they did not power so much the sectors to work in collaboration and come with their own creative ideas, creative juices, creative excitement. Certainly the LHINs, with all due respect, except of transitions in care, which is a guideline that we did develop as a request from the LHINs did not engage the associations the same way that now we are being engaged. So, you know, I kind of think of the LHINs now as the first phase for this. So it's not that it was wasted time, it was wonderful, but it was the first phase. Now the phase is kind of moving it to the field. So the field really coalesces together and works together. Together with that, we many times are asked, and I'm sure you guys are asking the phone too, why did we need this? Why didn't, you know, why couldn't we just continue to work together? Well, because we didn't. Because we didn't, that's the answer. Because as a whole, did you work with 30 partners before? I'm asking my colleagues here around the table. All of them are nodding no. When we ask others, so some, when we go to the Toronto East, some of them were already working together, but there was a lot of variety. Now everybody is being pushed to work together across sectors, and I think it will produce different results. But that's an excellent question. Any more questions, Olivia, before we close?
I have one more, and I'm not sure if you can fully answer it, but we'd love to hear your insight on it. Since this is the first time in history that the elderly outnumber youth, and also given a large part of the health budget is spent on elderly populations, will there still be options for that population to speak to a real person when they're trying to make appointments and get medical attention? This individual works in community nursing, and they spend a great deal of time trying to advocate for clients who feel they cannot get appointments within a reasonable time frame.
So I think that two things. The answer, I think, is yes. If anything, what is being tried here is to enhance the capacity to communicate. Many are putting care coordination. We are pushing also to put the 4,500 care coordinators right there in primary care for care coordination and system navigation. So the answer is yes. Also, let's please not assume, and I'm sure the person asking was not assuming that, but I'm talking broader for all of us, that older persons do not use digital capacity and virtual care. In fact, my 85-year mother-in-law uses it. So many older persons are using and in fact prefer that capacity so they can communicate more quickly. So I am hopeful that we will see more capacity to get care faster and access to care faster. And yes, there will be glitches. The point is to start to move, the same as we move from the LHINs to better, to move care and access to care to better also. Will it be perfect? Not overnight.
Wonderful. Thank you so much, Doris. I think we're all good on our end here with questions. So I pass it back to you.
Thank you very much. So in a month, we will have another one. We are in January, in February. I don't know if we have the date already.
We'll announce it. When we're
So we will, in the future, we will give you the date at the at these teleconferences. Apologies that we don't have it. Olivia, if you can get that date sooner rather than later with PG, please
Sure.
send an email and a note to all of the people in the call today. But in February, we will have another one. And if people have ideas, Olivia, of themes that they want to hear about, please send a note. Tell them how to send a note to you.
Will do.
Can you tell them how to send a note to you?
Sure, you can email me directly. It's oklej@rnao.ca.
Can you repeat it, please?
Of course, oklej@rnao.ca.
Fantastic. So with that, if you have ideas of future webinars, we're thinking, all of them on health system restructuring. We're thinking on the next one to bring an expert on the issue of indigenous people's health. If there are other aspects about the OHTs that you would like to hear, let us know. Also, let us know if you're not receiving the updates that RNAO is sending daily on the novel coronavirus. We're sending them to, of course, our 44,000 members. We are sending them also to non-members. If some of you are not receiving, please send a note to Olivia and we will make sure to put you on the list. And we are sending them to all of our BPSOs, 1,000 of them, to the lead people in those BPSOs. So if you are in a BPSO and you have not received an update, you can ask that person, they should have it. And we send them on a daily basis at around 5, 6, 7 p.m. Very good. Thank you to everybody for participating. And of course, there is a government website. I should tell people, given that I'm in those calls in the morning, there is a government website for providers now. That government website is open for providers. The notices that RNAO sends are meant for health professionals, not to be sent further to other people. And the website is open. There are 2 sides to the website, one for the public and one for health professionals. Okay, thank you very much.
Thank you.
Take care.